يعني في خروشه عندك بس دلوقتي
خروشة
كويس.
مم. طيب أنا عايز أبعد السكرين دي كده بعدها.
اتفضل.
بسم الله الرحمن الرحيم. النهاردة هنتكلم عن personalized approach للميكانيكال فنتيليشن. هو طبعا الترند عندنا دلوقتي في الميديسن وفي الانتنسيف كير عموما ان احنا نعمل personalized medicine. personalized medicine مش ان احنا بنinvent something new، ولكن مش زي ما بيقولوا كده، مش كل واحد بتلبسه نفس القميص، مش نفس البدلة، مش نفس الجاكيت. كل واحد ليه التفصيلة بتاعته. لا، اللي عايز الحتة دي تبقى ضيقة شوية، الحتة دي تبقى واسعة شوية. فزي الميلز غير الفيميلز، زي الادلتس غير البيدياتريكس. دلوقتي البيشنت بالكوموربيديتيز هيختلف عن غيره. انا سامع صوت زي ايكو كده. ممكن لو اي حد تاني عامل الفويس بتاعه يعمل له ميوت لو سمحت.
عملت له ميوت يا فندم.
مم. في ايكو كده. فحكايه البيرسوناليزيشن بتاع الطب كله هيبقى شغال بنفس الاسلوب ده ونفس الطريقه ان شاء الله. لان البيرسوناليزيشن ده بيبقى كمان على مستوى، دلوقتي بنتكلم في مستوى الجينetics ومستوى الدي ان اي والار ان اي، عشان ده ريسبونسيف تو ذس ميديكيشن، ده مش ريسبونسيف بناء على الجينيتك كود. ده وارد جدا ان انت هتواجه حاجات كتيره زي ما انتم شايفين دلوقتي ميديكيشنز طالعه ار ان اي بيزد ودي ان اي بيزد، وده هيعمل ريفولوشن في الميديكال تريتمنت اللي احنا شغالين بيها عموما. فالبيرسوناليزيشن في الاي سي يو كان ابتداها، كان اول حد سمعته بيتكلم عنها طبعا كان البروفيسور جان لوي فينسنت. وكان بيتكلم على ان النتائج بتاعه الاي سي يو في اغلبها، كل الاستاديز اغلب بتاعه الاي سي يو نيجاتيف ستاديز، وما بتطلعش فايده في المورتاليتي عظيمه، وما بتطلعش نتائج كبيره، غير مثلا اللو تايدال فوليوم ابروتشز اللي كانت في الاي ار دي اس نت مثلا. طبعا بس عشان كان فرق كبير ما بين ال 6 ام ال وبين ال 12 ام ال في السيتنجز بتاعت الميكانيكال فنتيليشن. انما اغلب الاستاديز لو تشوفوها مش هتلاقي فيها ميجر بريك ثرو في المورتاليتي بنفيت. ليه؟ لان طبعا بيبقى مالتي فاكتوريال، ما بيبقاش فيه الديث في الانتنسيف كير زي ما انتم عارفين كلكم. مش بتبقى جاست وان فاكتور. يعني ممكن البيشنت زي ما انتم شايفين بيخش بريسبيراتوري فيلير and he dies of renal failure and he dies of multiple organ failure, multiple organ dysfunction syndrome. نتيجة ايه؟ نتيجة الانتر كورليشن زي ما هنشوف كده مثلا من الفنتليتور انديوست لانج انجري، عملت له بايو تروما وانفلاميشن وميدياتورز طلعوا، خلت فيه سيلولار سيجنالينج، عمل اكيوت رينال فيلير، مع انه ما كانش عنده حاجه في الكلى، ما عندوش اي
دكتور
حاجه في الكبد، ما عندوش اي حاجه في الاذر اورجنز. طب وات
دكتور
هابن؟
ياسر، في بس حد من المستمعين انجلش سبيكينج فمش فاهم الكلام العربي، بيقول لو سمحت تخلي معظم كلام انجلش لا
Okay,
على لا.
I'll try to speak all in English, but excuse me, sometimes I speak in Arabic. Um I'm talking about personalized mechanical ventilation. Why does the patient have acute renal failure? Why does the patient have, but after just respiratory failure on admission, and he was just giving on mechanical ventilation, for example, and he was on the wrong settings of mechanical ventilation. He had biotrauma, as we will see, biotrauma and volutrauma and barotrauma. But biotrauma for by itself, okay, release of mediators, inflammatory cytokines, and cellular crosstalk, which signaled on the kidneys, which inflamed the endothelial dysfunction, had acute renal shutdown, while he had a normal blood pressure and he had a normal everything regarding the kidneys. So that's what we are seeing. We are trying to have a personalized approach for each patient, because each patient has his cumulative factors of comorbidities. Like, not all the studies will include your actual patient who has diabetes and has a left lower limb with diabetic foot, and he must have a certain medication on local on this local aspect, and at the same time he had a history of oncologic diseases, and he was on chemotherapy and radiotherapy. These kinds of patients that you see every day that are immunosuppressed or that are on anticoagulation or extremely old or extremely young, males or females, these are not the everyday patient or the classical patients that are included in the studies, because there are exclusion criteria, as you all know. There are exclusion criteria. Oh, we excluded patients who had renal failure. We excluded patients who had heart failure. We excluded patients who had diabetes, for example. Like, but if you have, your patient will have diabetes and will have heart failure and will have renal failure altogether. So he might have been excluded, and you are basing your approach on his treatment on some, you're extrapolating that it will give him benefit, and it will not, because it's not on the same exact person. And we have to accept that there are personal variations in the responses to the treatment. That's why we are doing now major studies about the cellular responses, the DNA responses, and so on. So, okay. I will start my first slide. Today we will talk about the mechanical. What is mechanical power? Mechanical power on the mechanical ventilation. What is VILI? What is the ventilator-induced lung injury? How will you calculate this mechanical power? And how will you make sure that mechanical power at the bedside, you can calculate it and you can measure it? What are the factors that affect this mechanical power that you are using, and how to make use of this mechanical power on the ventilator settings? Actually, this is the trend of what we have all seen before about patients. The treatment, since the invention of the mechanical ventilation, we are trying to avoid the barotrauma, the high pressures, and then we have realized that not only the pressure, it's the volume, and actually the pressure and the volume combined with each other. You cannot have a change in the pressure without the change in the volume, according to Boyle's law. So the low tidal volumes, low plateau pressures, we were concerned about that in the early days of initiating mechanical ventilation, of course. And then patients with ARDS, we have included the studies about the open lung approach, to insert PEEP, to raise the PEEP, and to keep the lung open by high PEEP, open lung approaches. And then after that, we have seen, that's not all the problem. We have to look at the driving pressure, not just the pressure, the driving pressure, which is the difference between the baseline pressure, the PEEP, and the plateau pressure, the inflating pressure of the lung. This is the driving pressure, the pressure needed to inflate the lung from the plateau, from the baseline to the plateau pressure. And then after that, every single item of those is included, and it is a major factor in our appreciation. But we have realized that you are injecting energy to this system. Energy, which is the work of breathing, as we know it. We have seen the work of breathing before. And if anybody knows how to remove this icon, I don't know how to remove the black thing. Okay, and the quarrel now is to include all these factors and assess the driving power, the ventilating power, which is called right now is ergotrauma. Ergotrauma, from pressure and power. This is the type of assessment that we are using right now, as you see, the ergotrauma, which has been introduced by Gattinoni and colleagues in 2016. Next slide. So, several studies, including ARDS and non-ARDS patients, have now demonstrated the association between mechanical power and mortality. The mechanical power of ventilation is associated with mortality in critical ill patients, in ARDS and non-ARDS patients. We have seen that mechanical power and 3-year outcome in ARDS has been shown to increase the mortality. As you see, there's a certain mortality difference and benefit in the patients who had less power injected to the system. Mechanical power more than 22 joules per minute was associated with mortality with a very high difference. Mechanical power and outcome The other studies have shown that the best cutoff was around 19 joules per minute, which has increased the mortality adjusted odds ratio to in-hospital mortality, as we can see here, that it has increased the mortality by increasing the mechanical power. So what is this mechanical power, and what is the ventilator-induced lung injury? This is the equation of motion. The equation of motion, I want to move that away. I don't know how, but I must move it away. The equation of motion. The equation of motion is the way the motion of air to for air to move from a place to another, it has to have a pressure difference. So it's a total pressure. Okay. Actually, this is the peak pressure that we are inflating in the lung. What do you need to inflate the pressure to inflate this lung? To overcome this resistance, the airway resistance, and then to overcome this lung elastance, and then to maintain this opening. So you have pressure to move the gas, pressure to distend the gas, and pressure to keep the lungs open, to inflate, to overcome the airways, and to distend the lungs, and then to keep these lungs open. Okay? So this is the equation of motion. So it's included, it's totally different mechanics here. If you want to know the mechanics of this airway, it is the airway resistance multiplied by flow. And the mechanics of this elastic portions of the lung is what is the elastance multiplied by the tidal volume. And at the end, to maintain and to keep these lungs open, you must have a baseline pressure, which is the PEEP. So this is the equation, the famous equation of motion that we all should know, to have pressure inside your lung. What about the mechanical power? So mechanical power is not just the amount of energy transferred from the system. It's it is the cumulative inflation of the energy per minute. Okay. It is the amount of energy transferred from the ventilator to the respiratory system within a given time frame. So on the left hand side here, as you can see, the motor of an engine of a car. How do you evaluate the power of this car? You evaluate by the horsepower. You say this car is has 200 horsepower, it has 500 horsepower. The power is by the RPM, the rounds per minute of this motor. This motor, you have RPM, rounds per minute. The more you increase the RPM of your motor, you will have more horsepower, right? So when you increase the power, the cumulative energy per minute, the injections per minute, the inflation energy per cycle per minute, you will have more power, more energy transferred from this side to the other side. Okay, so I want to inject energy to the system. If you have a mechanical ventilation, you have the tidal volume that is giving in there for how many cycles, how many rounds per minute, for 30 rounds per minute, 40 per minute, 60 per minute. You increase the mechanical power by increasing both the volume, by increasing the pressure, by increasing the rate, as you will see. On the right hand side, you have Jerry here. You will not have this nail pumped up inside this this part. How can you have just one tap by the hammer? No, you hammer many frequency times, so you have a bigger power. Okay, so mechanical power is very important to know. Mechanical power is the amount of energy transferred from the ventilator to the respiratory system within a given time frame, which is per minute. That's inflation cycles per minute. Okay, joules, so that we by joules per minute. Okay, joules is the energy, as you all know. And here is another example to have a fight with this. Can you hear me? When you have a fight here, you have not just with one punch, you need many punches. So this rope, if you have one punch, two punch, three punches, and at the end you will break it. So this is the difference between just one breath or one work of breathing and the power. The power is the repetition of this energy per minute, to have a frequency, a rapid frequency per minute, to increase this energy in the form of power. So that brings us to the aim of our respiratory support, the mechanical ventilation. What are we trying to do? You are trying to buy time with minimal damage. As you all know, mechanical ventilation comes at a price. It comes at a very big cost. What is this cost? Is the lung injury. Just putting the patient on mechanical ventilation, you are injecting what? You are injecting power. You are injecting energy. And this energy is damaging. It damages all the constituents of your respiratory system, of the alveoli, of the bronchi, of the cells inside. So you are giving damaging factors. So how to minimize this? What is our role here in mechanical ventilation? Our role is to minimize the damaging factors by the ventilator, which is the mechanical power that you are giving. Give less energy, please. Less energy in the form of what? You will see in the form of the tidal volume, the respiratory rate, the peak pressure, the driving pressure. All the components that you have seen in the equation of motion are components in the mechanical power. So they induce more energy, okay? And there are damaging factors in the ventilator and in the patient himself, of course. How can I treat this patient? He has a baby lung size, he has inhomogeneity in his lung. I will try to make it a more homogeneous lung. I will try to make that by your maneuvers, like recruitment maneuvers that you have done, or make the patient prone position on his face, and all these maneuvers in trying to what? To make the lung a little bit more homogeneous, so you can deliver the pressure without more energy dissipation, without ventilatory alarms. Okay? Are there any questions here? I don't see any comments.
الهوموجينيستي مش واضحة، يعني ايه نعمل ايه عشان نخليها homogeneous؟
Homogeneity, the heterogeneous lung, as you know, the lung will be heterogeneous affected. The apex is not like the base, the dorsal is not like the ventral. As we have seen in COVID, for example, the ground glass appearance, the heterogeneous opacities. What we do is that we try to make parts of the lung more homogeneous than the other, to recruit the non-inflatable parts. And we do that by the recruitment maneuvers and by PEEP application to keep the atelectatic parts open, and by prone positioning. Prone positioning, this is another lecture, of course, but it facilitates to make the lung more homogeneous by making redistribution of all the gravitational forces that you know. All the gravitation forces, instead of being all in the dorsal and the flat part of the posterior aspects of the lung, no, we will twist the patient and make him lying on his face, and the lung will be inverted to the prone position, and this inverts the gravitational forces, would be more down, and the weight of the heart itself in the mediastinum will be on the sternum. So it tries to make the lung more homogeneous. This is what is in our hands. No magical tools. Okay. The ventilator related factors. Our mechanical ventilation, the related factors are the pressure, the volume, the flow, the respiratory rate, the PEEP. All these factors, they cause the barotrauma, the volutrauma, the atelectotrauma, and the biotrauma. So before starting any battlefield, you must know your boundaries. So what is your boundaries in mechanical ventilation? Your patient has boundaries. What is the boundaries of this patient? The boundaries is can any patient, you can give him a tidal volume of 3 liters, 4 liters? Of course not. Okay. And any patient, you give him a tidal volume of 4 mLs per kilogram for 100 tidal volumes? Of course not. You must know your boundaries or your battlefield. You're entering this battlefield and you have boundaries. The boundaries is this is a normal spirometer of a healthy adult. There is the resting lung volume, which we call the FRC, the functional residual capacity, which is the tidal volume that the lung rests at. Okay. And this is, of course, when you decrease, this is the maximal expiratory force, and this is the maximal inspiratory capacity. Above the FRC, the inspiratory capacity, you do maximal exhalation, then you do maximal inhalation. This is what the inspiratory capacity. So this is your actual limit. Your actual is actually in a healthy person is 80 mLs per kilogram per body weight, okay, per predicted body weight. So what do we do in? Do you have healthy patients in your ICU? Of course not. Of course, if you have a healthy patient, you're lucky. But what do you do when you have this? This is in the back of your mind. The normal FRC for the patient is around 2,500, and the inspiratory capacity mainly should not exceed, as you see here, this is the normal tidal volume. Normal tidal volume should not exceed the FRC. It's maybe, if it's the exactly the same, maybe 8 mLs per kilogram, and this is the same, the FRC. If you increase the maximal inspiratory capacity, this is nearly what? How many times is this relative to the FRC? This is mainly 2 times, 3 times the what? The FRC. The total lung capacity here is around how many times? Around 3 times the FRC, the functional residual capacity. So this is your boundary. This is your limit. You should never inflate the lung more than what? More than 2 to 3 times your FRC. Again, you should never inflate your patients in the maximal tidal volume for you is to be the maximum volume to be 2 times or 3 times maximal your what? Your FRC, your functional residual capacity. Okay, so tell me, doctor, okay, the FRC in a healthy patient is around 2 liters. So what? I can give 6 liters for this patient. No, sir. The FRC changes. It changes with every patient who is affected. You should reassess and should re-estimate this FRC or for this patient according to your. Have you heard about the baby lung concept? Yes, it became a baby lung. It became a shrunken lung. A shrunken lung has it has an FRC of 500, and you are giving him a tidal volume of another 500, so you have a maximal risk of injury. So again, you should know your boundaries of your battlefield. You should never give a tidal volume which is greater than the FRC. And if this FRC is decreasing by the heterogeneous affection of lung, as we have just said, this heterogeneous affection makes your lung, your lung is not stiff, your lung is small. There are parts of the lung which are not functioning at all, okay? The rest of the lung which is functioning, it is actually small. The only you will have a baby lung that is functioning for an adult. So his FRC is of a baby. So you give him a tidal volume of a baby. If you exceed that and you estimate on his original FRC, you are doing him a catastrophe and you are giving him maximal barotrauma and volutrauma. This is an example of what we are saying. On the left hand side, this is the FRC. This is the skeleton of your alveolus. Okay, it is bound by a skeleton of proteoglycan and collagen and collagen, as you see here. This is the collagen curled around itself like that. And this is when you approach the total lung capacity, nearly 80%. What do you see here? All the collagen is what is straightened out, it's pulled out, it's enlarged. You see this size here and the size here. The skeleton is nearly overstretched. Everything here is stretched to the maximum. Okay, so once you reach the total lung capacity, like this balloon here, you have reached this total lung capacity. Just one more increase, you burst your balloon. This balloon burst. And what you see here by electron microscopy, you have interstitial stress-bearing elements here. What do you see here? It's a cracking inside the cells, the epithelial cells, the endothelial cells, the microvessels, the capillaries. Okay, that's why you will have lung edema and inflammation, and this inside the cellular comes out here, and biotrauma with inflammation and inflammatory cells activation. Okay, you don't essentially have you must see surgical emphysema, aneuromediastinum, aneuromyoperitoneum. No. This, the first thing that will happen here is the biotrauma. By your stretching, you overstretch the cells, and you manage to do these breaks and these small insults on the cellular level, that you have what you will have: biotrauma, you will have volutrauma, you will have barotrauma. Okay, this is a microscopy from an alveolar wall. The interface between the visceral pleura and the parietal, and the difference, the interface between these two structures, it's a stress razor. These points, you have, this has different compliance and that compliance. If you have pressure at this point, very high pressure, this small capillary here inside, you have pressure inside the capillary, increase in lung inflation from outside, from here, and shear stress, shear pulling on this side, you will have a crack here. You will have, what you will have, this is the shear point, this is a shear stress, this is stress razor. You will have pulmonary edema, interstitial edema here, and you'll have blood and alveolar flooding here inside, and you'll have diffuse alveolar damage. Alveolar damage does not only concern barotrauma and air to leak. No, here when you have this, you have capillary leak, you have edema, you have inflammation, you have inflammatory cells, which will increase the burden of your ventilator-induced lung injury. This is the picture of the lung after just 20 hours of giving high strain, a very high tidal volume, 45 ml per kilogram, and this is after 52 hours. The same hours, nearly, or this is double the time. I'm sorry, this is double the time, but a nice lung because you don't have maximum strain. Here you have a very high strain. We said I will explain the strain is what more clearly later, but strain is the longitudinal elongation of the cells. You have injured this cells by overstretching the skeleton. You have exceeded your boundaries of the lungs that we have said. You have approached nearly the total lung capacity by giving him a 45 ml per kilogram. What you see here, blood everywhere, and you increase if you weigh this lung, you will have it, it's full of water, it's full of interstitial edema, it's full of blood. Why? Because you have injured this lung by giving it barotrauma and volutrauma, and before that stretching and biotrauma. This is an example of ventilator-induced lung injury. This is the biotrauma that I'm telling you about, the inflammatory mediators, the cells, the edema. And this is the biotrauma and barotrauma and volutrauma, increased pressure and volume at the same time. You will have, all the time you have increase in pressure, you will have an equivalent increase or change in the volume. This is the stress-strain relationship that I'll show you. So stress-strain relationship is pressure-volume relationship. Any change in the volume will have an equivalent change in the pressure with a different view, okay? And this is atelectotrauma also, atelectotrauma that you do not inflate it enough, so you'll have a very shear stress between every time you need to inflate again, and it collapses at the end of expiration. So that's why you put what? You put a baseline pressure like PEEP, so you do not have de-recruitment in exhalation. You have to recruit all over again from every inspiration, okay? So all these stresses, the biotrauma that we have said, the atelectotrauma due to the inefficient inflation, okay, and the de-recruitment that happens in exhalation, and the barotrauma and the volutrauma, the overstretching of the lung skeleton, and you're exceeding your boundaries, and the stretching of proteoglycan and the collagen, and eventually you will have ruptures in this alveoli, as you can see. All these factors increase the inflammatory mediators, decrease the oxygenation, increase the carbon dioxide, and they go to the other organs. You will have multiple organ dysfunction syndrome. You will have a ventilator-induced lung injury is a multiple sepsis. At the end of the day, what is sepsis now? Sepsis is a dysregulated host response to infection, and you evaluate it by what? It's not an infection by an organism. No, it's a disproportionate response, dysregulated response to this infection which had happened somewhere in the lung for pneumonia, for example, and you have a biotrauma. But what increased it and made the organ dysfunction is the biotrauma and the organ dysfunction that will happen due to cellular signaling and due to the cytokine burst and the storming that will happen, okay? So Again, we will revise the ventilator-induced lung injury. It is composed of ventilator-associated factors set by you, which are the keys. Lung protective ventilation is what? Is protect the patient from the doctor. Protect the patient from the doctor, said from this clinician. Protect your patient from excessive tidal volume or from low tidal volume. Protect your patient from high air pressure or low air pressure. Protect your patient from high inspiratory flow or low inspiratory flow or disproportionate respiratory flow. Protect your patient, protective ventilation, by disproportionate respiratory rate or disproportionate PEEP. So you are the clinician, you are doing the personalized approach. You will have, as you will see, an increase in tidal volume will increase the ventilator-induced lung injury, and vice versa. The decrease will also do that. And the lung conditions that you have known, the inhomogeneity, the increase, the stress fractures that happens there, and the increased homogeneity, as you have seen. You will try to increase the homogeneity, but it's not actually in your hands to master everything. But as we have said, you might do the prone positioning, recruitment maneuvers, cyclic inflation, collapsing, and so on. So we have seen that. So back to mechanical power. How to calculate that? How do you calculate this? This is the equation of motion, though I want to remove that again. The equation of motion again is the total pressure given is what is composed of a resistive pressure load, the elastic pressure load, and to keep the lung open. Inflate the lung, pressure needed to inflate the lung, to distend the lung, and then to keep the lung open. All these are the components of the work of breathing, or the equation of motion that enters per breath. The mechanical power is what is, as we have said, this is one hammer. This is one hammer on the head of the nail. We want the continuous hammering. We want the rounds per minute of this motor. So this is multiplied by what? Multiplied by the frequency, by the respiratory rate. So if you the work is what? The force multiplied by the distance, and the power is the rate per minute. I want to get this out of the way. So imagine I want to put this here. So this is the equation of motion again. Peak inflation pressure, as you can see, this is the famous pressure curve that you all know, is the resistive pressure load. This is the resistive pressure load to overcome the trachea and the bronchi. This is what is the resistance multiplied by flow. This dot is here, okay? Resistive pressure load, this part, and then plus the elastic pressure load that I have to inflate the alveoli. So what do I do? After I inflate the airways, I inflate the lung, which is composed by the plateau pressure. And the equation is the tidal volume divided by the compliance, okay? And then to maintain the lung open, which is the baseline PEEP down there. Okay, so this is our famous pressure curve, the peak inflation pressure, and the work of breathing is what is all the area under this curve. The work of breathing is the area that we have done during this inflation, and after that, the power will be multiplied by this area under the curve per minute. Okay, so again, this is the equation of motion, which is the peak inflation pressure is both the resistive pressure load, the pressure needed to overcome the resistance, which is the bronchi, the trachea and the bronchi, and then the pressure needed to overcome the elastance, which is the lung itself, the balloon of the lung. Okay, of course you know how to differentiate between both. I know the pressure, the peak inflation pressure, and how will I know the difference? I will do zero flow here. If I do the inflation and then I'll hold my breath, this is the plateau pressure at zero flow. So when I have zero flow, the component here of this equation is what? R multiplied by zero, resistance multiplied by zero. There's no flow, zero flow. R multiplied by zero is zero. So if this part of the equation is zero, you remove that from the equation. So the pressure inside, after you inflate the lung, you have a pressure inside the lung. You didn't exhale yet. You have lung inflated like that, and you have pressure inside this balloon, right? This pressure is the alveolar pressure, is the plateau pressure. So if I know now the alveolar pressure or the plateau pressure or the end inspiratory distending alveolar pressure, so I can subtract peak minus plateau is the resistive pressure load. This is the peak minus plateau, as you all know, is the resistive pressure load of the resistance which is for this trachea and the bronchi. Okay, so all these factors under this curve participate in elevating the peak inflation pressure. As you know, if you increase PEEP, you increase the peak inflation pressure. If you increase the tidal volume, you increase the peak inflation pressure. If you decrease the compliance, you will increase the peak inflation pressure. And of course, the plateau pressure, all of this, under everything under each one of them will increase it. But if you increase here the flow or the resistance, you will only increase what? The peak inflation pressure. You have no effect on the plateau pressure because it is above it, right? This is the pressure needed to overcome the resistance and the flow inside the bronchi and the trachea. Okay, so this is the equation of motion again: resistive pressure load plus elastic pressure load, and you know how to differentiate between them by inspiratory hold maneuver like that. If I know the peak inflation pressure, I'm minus the plateau, so this is the difference done by the resistance. Anything under the curve increases the thing above it. The PEEP will increase everything above it, including the plateau and the PEEP. Okay, the peak. Sorry. The tidal volume, if you increase the tidal volume, you will increase the plateau and you will increase the peak also. If you decrease the compliance here from the equation, you decrease the compliance, something you are dividing upon it. If this is decreased, so the peak inflation pressure will increase from the equation. You increase the tidal volume, you increase the PEEP. You decrease the compliance, you increase the PEEP. If you increase the PEEP, you increase the peak inflation pressure, all from the equation. And but if you increase the resistance or the flow, you don't affect the pressure because it's above it. Okay, you only increase the PEEP, the peak. Okay. So ergotrauma is what is the trauma done by the power. The power which what did we add to the equation of motion here? We only added here what? The respiratory rate. So you have the work of breathing by all this is the equation of motion, and multiplied by respiratory rate or the minute ventilation by itself, you will have the power. The power is the energy injected per minute in the system, and every single component here, the PEEP is the atelectrotrauma, the tidal volume, the compliance, and the resistance and the flow are all components that do what? Barotrauma, of course, barotrauma, and the volutrauma, atelectrotrauma, volutrauma, of course, the tidal volume itself, every component of that. And this is what you say chronotrauma. We will say that every component is a part of the power, and then the biotrauma itself is part of the constituent of the injury that you do in your ventilator-induced lung injury by the mechanical power. The idea here is that you will know that every single component is not by itself. So by exclusion and by omitting part of and by manipulation of these equations, you only added the mechanical power here, the respiratory rate here. By omission in this equation manipulation, you have this equation. Now it's very feasible mechanical power, a very straightforward, easy equation. What do you do? The peak pressure that you have from it's manipulation of the equation of motion, as you have seen. Peak minus half the driving pressure, which is the plateau, minus PEEP, multiplied by the minute ventilation, which is the tidal volume, respiratory rate, and this is the correction factor. Okay, again, this is a very nice and the very important part here. The calculation of the mechanical power is peak minus half driving pressure multiplied by minute ventilation. The driving pressure is the plateau minus PEEP multiplied by tidal volume multiplied by respiratory rate and the correction factor. All this has been derived from the equation of motion that you have just seen. So there are many methods. The first method to assess the equation of motion, there's a method from a quasi-static, from a very slow pressure volume curve of the respiratory system, but you do not include the PEEP here is not included here. So you have the total area is the area under the curve, the energy transferred to respiratory system. Another method, This is the equation method that we have just explained. The equation includes everything. It includes the static component, the elastic, the resistive, and the static components, resistive pressure load, elastic pressure load, and the pressure needed to keep the lung open, as we have seen. By manipulation of this equation, we will have the mechanical power that you have seen. The last method is the intertidal inspiratory pauses. But this you're not using the pressure, you're using the transmural pressure here. So it's an equation that's using the driving mechanical power here, but actually you do not use here. Also the PEEP is not included. These are all methods and sophisticated methods of calculating the power, but actually I'll show you how to calculate it bedside very easily. The total work, as you've seen, is the area. There is area of the parallelogram. This is the parallelogram, as you see. It has this equation. You have resistive work is the base multiplied by height. This components here, the pressure versus volume versus pressure curve here. Peak minus plateau. This is the base and the height. Peak minus plateau multiplied by the tidal volume here. The area of the triangle here, you will have, this is the tidal power, this is the elastic pressure load. So this is the resistive pressure load, because you know from the equation of motion that the peak minus plateau is what? Is the resistive pressure load. We have said it's formed by resistance and the flow. And here is what is the elastic pressure load, which is composed by the tidal volume and the compliance. This yellow part, it's a triangle. How do you measure the area of the triangle? Half the base multiplied by height, which is the pressure airway. Every one of here is the pressure, and this is the tidal volume. As a compensation in these equations. And the area of this rectangle is the PEEP minus the related work, is the PEEP related work done. So by manipulation of these areas, you have the area of the parallelogram, which is resistive pressure load, area of the triangle, which is the elastic pressure load, and the green area, which is what? The PEEP and the baseline pressure related work, PEEP related work. Okay. So the total area, this is the equation that we do, is the PEEP plus half the driving pressure, which is the plateau minus the PEEP, plus peak minus plateau. This is the equation. So practically, this is the case. Everybody concentrate with me now, okay? This is a very, very easy example. Oh, this is the equation I put for you here. The peak minus half plateau minus PEEP multiplied by the minute ventilation, which is tidal volume, multiplied by respiratory rate and the correction factor, okay? Peak minus half driving pressure multiplied by minute ventilation multiplied by 0.1, which is the correction factor, is the joules per minute. This is a screenshot from the ventilator, okay? The clinical scenario that you have all seen. A patient who is a male, predicted body weight of 80 kilograms, came with acute respiratory failure during the COVID epidemic. He's on volume controlled ventilation. He is on muscle relaxation and prone position. Okay. Again, he's a patient who was in COVID with acute respiratory failure and volume control ventilation. As you see here from the curves, you have a peak and plateau and a rectangular flow curve and tidal volume. And he's on prone position, he's on muscle relaxation. A classic case that we have all seen during the COVID epidemic. So calculate the mechanical power for this case. How do you calculate the mechanical power? Calculate the mechanical power. Look at this equation. Peak minus half. The plateau minus the driving pressure is the plateau minus PEEP, multiplied by tidal volume, multiplied by respiratory rate, multiplied by 0.1 correction factor, joules per minute. So where is the peak? Peak pressure, where is it? Anybody see the peak pressure?
34.
Here's the peak, 34. Okay. Yeah. Where is the plateau pressure?
21.
Yeah,
21. Where is the PEEP? 8. So the driving pressure is what? 21 minus 8. Okay. 20 minus 8 is what? 13. And then what we'll do? Multiplied by the tidal volume. What is the tidal volume for this patient? You can see it here when I elevate it. It's what? 480. This is the tidal volume, and the frequency is 25 per minute. Okay. You can also calculate it. I told you his predicted body weight is 80, and his ARDS patient, so 6 ml per kilogram. 6 multiplied by 80 is what? Is 480 milliliters. Okay, so multiply by where is his minute ventilation? His minute ventilation is 480 multiplied by 25. Here you can read the minute ventilation is 11.9, or you can say it's 12. Okay, so here it's 12. So overall peak minus driving pressure, which is 0.5, the driving pressure 0.5 multiplied by 21 minus 8 اللي هو 13. 34 minus 0.8 multiplied by 13, 34 minus 6.5 multiplied by the minute ventilation, which is the tidal volume, multiplied by the respiratory rate, which is 12 liter per minute here, multiplied by correction factor is 0.1. Can you do this for me? 34 minus 6.5 is 27, multiplied by 12, multiplied by 0.1, at the end 33 joules per minute. Is this good or bad? 33 joules. 33 joules is very bad. As you have seen, as I've shown you from the earlier, the very first slides, the cutoff we have seen around 19 and around 22. 22 is associated with mortality in 3-year mortality, with immediate mortality, with it's a very high number, 33 joules per minute. You should have it around, should not exceed 17. So you tell me, doctor, this patient, that's the problem, or this is the idea of the whole lecture. The idea of the whole lecture that you will see here, not a single component. There is always a multi. It's very unfair to just say that the driving pressure is injurious, the plateau pressure is injurious, the tidal volume is injurious, you have exceeded tidal volume, the respiratory rate is injurious. Okay, it's unfair to say a single factor. You cannot say one factor. It's a multitude of factors. As we have seen here, you can estimate the plateau pressure is not so high, it's 21. The PEEP is not so high, is 8. The peak pressure, okay, is 34. We can see that every day in our ICU. Okay, so why do we have here an elevated mechanical power? Okay, maybe it's the respiratory rate, maybe it's the minute ventilation for him, maybe it's it's a multitude of factors. Maybe we have to the factors collectively are exceeding. We have no, if you have every factor alone, we are not exceeding the 6 ml per kilogram RDS net parameters. Here the plateau, we are not exceeding the 30 centimeter water of plateau pressure, and we are not exceeding, of course, the driving pressure of 15. It's 13 here, but you are close. You are close, or you are just at the boundaries of every limit of them. So the thresholds of each collectively are still injurious. So this is the question to be answered for all of you. It is not a single factor. It is not one factor. That's why you must personalize your patient. Even if you obey all these factors that are within the limits, you are still having a problem with the mechanical power, with the energy that you are delivering, the injurious energy. If you increase the energy, given you are increasing the ventilator-induced lung injury. Energy is injury. Okay, so this is the example that is very nice. If you take a look at it and repeat it if you want with yourself, it is very easy. Peak minus half the driving pressure, which is the plateau minus PEEP, multiplied by the minute ventilation, which is the tidal volume multiplied by rate, multiplied by 0.1 as a correction factor. You will have at the end joules per minute. If you are exceeding the threshold factor of 17, you're in trouble. Okay. What about the stress and strain? This needs us to look. I've put these cartoons for you. What is this? This is an airplane here above, and this is a submarine below. Why do you think the patients? This is to increase our understanding of mechanical ventilation. What's the relationship? This is a cabin, and this is a cabin. Okay, the cabin inside here, the cabin crew inside the submarine, and the cabin crew inside the airplane. What happens to this airplane? This airplane elevates in the atmosphere. What happens when you elevate? You reach right 2 kilometers, 3 kilometers above the atmosphere. What happens above? The more you are elevating above sea level, the more the barometric pressure decreases. Okay, So the pressure outside the cabin of this plane, what happens to the pressure outside the cabin? Decreases. So what do you think should happen inside the airplane? He must equalize the pressure inside the plane with the pressure outside the plane by decreasing the pressure inside. Like when you if you are asleep, when the plane elevates, what happens to your eardrum? You will have you cannot hear your eardrum. You must swallow. So you open your own stick tube. So you equalize the transmural pressure. The transmural pressure is the pressure inside minus the pressure outside. The pressure inside your pharynx minus the pressure outside your eardrum. So when you swallow, you equalize the pressure inside and outside your eardrum, so your eardrum does not explode. Okay, it does not implode at this situation. So if the pilot does not decrease the pressure inside the plane, what will happen to it? It will explode, right? The pressure inside will be much more higher than the pressure outside, so it should explode, right? On the contrary, here, the submarine, the same principle, but the opposite. When you go under 10 meters underwater, you increase 1 bar. Another 10 meters, 2 bar, 3 bar, 4 bar. What do you mean? What do you mean bar? Barometric pressure multiplication. 760 multiplied by 2, by 3, by 4. You are increasing. If you decrease down to just 50 meters or 100 meters below sea level, he must increase the pressure inside the submarine to equalize with the outside pressure, which is 10 bars, for example. 10 bars, okay? 10 bars is around 7,600 millimeters of mercury. How can your lung deal with that? 7,600 is how many centimeter water? I don't count. Maybe 10,000 centimeter of water inside your lung, and your lung does not explode. How does that happen? Because the key here is not the number, it's the transmural pressure. If inside minus outside is okay, so nothing happens. Inside minus outside is normal, no gradient, no explosion, no implosion, nothing happens to your submarine, nothing happens to your plane. Okay? So the pressure does not, the plane does not explode, and the submarine does not implode on itself. Why? Because they equalize the pressure inside minus outside, the transmural pressure. Relate this here to this lung. Can you see this? What are these? This is the bars inside, like any skyscraper, any wall, any ceiling and floor. Do you think there is no stress here? There's no tension. There is no pressure here exerted. Of course there is. There is the weight of the 100-story building on this just column. What do you think the pressure here is? If I sense the pressure, I'll sense tons and tons of pressure. So why doesn't it explode? It does not explode because inside minus outside, here and there are the same. So there is no motion. There is no difference in the pressures. So there is no strain. Okay. The stress is the tension, the pressure applied. Okay. The strain is when there's a difference between the here and if imagine that this pressure here is not confronted by a pressure here, 10 tons of pressure confronted by 10 tons. If it's confronted by only 9, what will happen? All this will crumble and crash. Okay. So the idea is inside minus outside. If there's a gradient or not. If there's a gradient or not. Look at this person. Look at this person. Can you see how his mouth is inflating this trumpet person? This player, this musician? What do you think he's doing? This is his lung, for example. Do you know how high a pressure he can give? He can give a pressure of 150 centimeters of water. You can give a pressure of 100 centimeters. You can inflate a very huge thing by your own mouth. What do you think the pressure inside his alveoli when he's inflating his mouth like that? What is inside the alveolus? It's 150 centimeters water too. 150 centimeters, yes, 150 centimeters water. and he doesn't have a rupture alveoli, he doesn't have a tension pneumothorax, he doesn't have barotrauma or volutrauma. No, he doesn't. Why doesn't he? Why doesn't he have barotrauma or volutrauma? Do you know why? The same principle that I was just talking about, like this column, like the submarine, like the airplane, because he has equalized the pressure inside with the pressure outside. What does he equalize? He has equalized his pleural pressure. He has made an extreme pressure with his extra respiratory muscles of expiration. He makes extreme pleural pressure, which counteracts the pressure inside the alveolus. So if he has a pressure of 150 inside here, he will also have a pressure of 150 centimeter water inside the pleural, generated by his muscles of expiration and muscles of his thorax. So inside minus outside is negligible. 150 minus 150 is 0. So there is no pressure difference. So there is no what? No barotrauma or volutrauma. Okay, got it? So the idea, the key is the transmural pressure, inside minus outside. The same thing. You can elevate, you can have a pressure. Don't tell me the pressure is how much. The idea here is to tell you that it is not the pressure, it is the transmural pressure. It is the pressure inside minus outside that influences or that affects the environment inside. So how can we do that with the lung? You can measure the pleural pressure. Do you know how to measure the pleural pressure here? Because you will have the transmural pressure is what? Pressure inside the airways here minus the outside pressure, which is the pleural pressure. If you have people 14 here and the pressure outside is 14, I must measure this pleural pressure. By what? You know what? You know how? By an esophageal balloon, like in the nasogastric tube, you have some kind of balloon in it, and you can the patient swallows, and you adjust its position inside the mediastinum, so it gives you the accurate reading of the mediastinal pressure, which is roughly equivalent to the pleural pressure. Of course, it's not the whole lung that is measured. It's an average of all the lung. You will see, because the lung by gravity, the higher part has a different pleural pressure than the stagnant lower part, and the ventral is different than the dorsal, and the superior is different than the inferior, like any column of fluid. But average is the pleural pressure here. So if you want to have the transmural pressure, or the pressure inside minus the pressure outside, you have to do what? You have to measure the pleural pressure. So here, if I have equalized, if I have a pressure inside the lung, like this musician, if he has a pressure of 150 here, but the pleural pressure is also 150, the pleural pressure, so 150 minus 150 is nothing, is 0, so you have nothing. Here the same, if you have a pressure of inflating pressure of 14, and you already have the disseminated pressure inside the lung, or the chest wall is very thick, giving a pleural pressure of 14. So 14 minus 14 is 0. So you have no lung injury here by doing what? The transpiratory pressure. These are other examples. Look at these examples. On the left hand side here, this is a normal breathing. If you have normal breathing, you have minus pleural pressure of minus 10. Okay, minus 10 is what? Minus 10, negative pleural pressure of 10, and the 0 here. So 0 minus 10, 0 minus 10 is what? Is plus 10. Again, if you have normal breathing, there is a gradient and there is a transmural pressure. If you have minus 10, massive minus 10, like that, you will have 0 minus 10 is 10 centimeter waters. Take care of this, because when you have, maybe you have seen that in COVID patients. When you have seen COVID patients, like patients who are only spontaneously breathing, and actually I've seen it myself. I've noticed the patients with spontaneously breathing, the patients who are only on non-invasive ventilation, had more pneumothorax than the patients on positive pressure ventilation. Can you imagine that? How come? Is it very alarming? How can a patient who is breathing negatively, he has negative pleural swings, have pneumothorax or barotrauma and volutrauma more than the patient who is on positive pressure ventilation. That is why. This is the reason. Look at this region and concentrate with me for a second. This patient here, if he is on CPAP 10, okay? Like a patient, he's here he said he's intubated with positive pressure ventilation, and you put him on CPAP of 10, okay? This is the alveolar pressure here is 10, okay? And he's not sedated. He has starting to become very nervous on this ventilator or on this CPAP, and he's taking very rapid or very big negative pleural swings, pleural swings, which are like minus 15 here. You have minus 15, and he's already here 10. So what is the transmural pressure here? How is the barotrauma going with you? 10 minus 15 is 25. So, oh, this is injurious. Oh, this can be injurious. This can be injurious. If you have negative pleural swings here, so I'm talking about only of CPAP of 10 or pressure support of 10. What about if you have a pressure, plateau pressure here of 30? Imagine this was 30, and he had a negative pressure, negative pleural swing. You have a negative pleural, imagine this was 30. 30 minus 30 minus 15 is 30 plus 15. 30 plus 15 is what? 45. You will have 45. Oh, this is volutrauma, barotrauma, end of patient, right? And you did nothing. You were obeying the rules. You had a plateau pressure of 30. But what you did not obey here is that you allowed him to take a massive or a very significant negative inspiratory effort, which you should have paralyzed this patient, full sedation. He shouldn't have had this opportunity, because when he has this negative pressure, it's in the same direction. Now, this is positive 30, as we said, and this is negative is plus, minus is plus, minus the outside pressure is an addition, because it pulls in the same direction. Okay, so if you have here a plateau pressure of 30, and you allow the patient to take a negative inspiratory effort of only minus 10 or minus 15, it's an addition to your lung injury. It is not on the contrary, it is an addition to the lung injury, and you will injure this patient, and you will have barotrauma in the fact that it's very injurious. Okay, you will have lung injury even if you have a spontaneously bleeding patient and you are obeying all the rules, because this is what happens. Remember always the guy with the trumpet. He can inflate with 150, but what does he do? He counterbalances this pressure by increasing the pleural pressure. Here you have not counterbalanced it. You did not counterbalance, but in the fact you decrease the pleural pressure in the same direction, so you will have an additional lung trauma. This is why I have seen during the COVID epidemic, I have seen the patients on non-invasive ventilation who are spontaneously bleeding, they actually had more pneumothoraces and chest tubes beside them than the patients who were intubated, because the patients who are intubated are fully paralyzed, fully sedated, they don't do this stuff. So this is not always, that's why we say patients with very mild ARDS, okay, try with them on non-invasive ventilation. But once the patient had a very high respiratory drive, don't do it. Leave the patient or intubate the patient, or because you have to fully sedate him so he does not injure himself by the cumulative transmural pressure happening that injures his lung and causes barotrauma and volutrauma. Okay, this is another example of if you increase the pressure of the pleura, this 30 minus 20, the only 10. If you have a 30 and this is the counterbalanced by his own pleura or another thing with a thick chest wall, he will not have any injury to his lungs. Okay. This is the classic pressure volume curve, but actually you use only the volume and the actual pressure. This is the peak part, the parrot peaking. This no change in volume but increase the pressure. That means you are over distending the lung here. You're over distending. You're trying to increase the volume, but it's not increasing, and you're only increasing the pressure. So this is the point of the maximal pressure that you're increasing, which is probably equivalent to your maximum lung capacity. And this part is the part where the lung will have atelectasis, so this is the lower inflection point, or maybe it's better to take it on the expiratory flow curve. So the point of de-recruitment here, or the point of, this is the point of inflation. The curve changes from this very high slope to this is the better slope, like that. This is the point of application of PEEP, increase in the compliance, and this is the point where the compliance is very bad, the declines, and you have volutrauma and barotrauma. Okay, so do we still use this? A better application is this. What is this? It's the difference. It's volume pressure also, but what volume? The tidal volume relationship to the FRC and the TLC, to the total lung capacity, and to the resting lung volume, which is the FRC. And in relation to the transpulmonary pressure, which is not the pressure that you have measured, it's the transpulmonary pressure that we are talking about, the transmural pressure, the pleural pressure minus the outside, the airway pressure or the alveolar pressure minus the pleural pressure that you have seen outside. So we have seen here that the transmural pressure, this is a stress-strain relationship, the elongation ratio to the tension. So when you have a stress-strain relationship of 1, it actually means you have a transpulmonary pressure, which is the specific elasticity. This is the relationship between each other. The relationship between volutrauma and barotrauma. Barotrauma and volutrauma are interrelated. They are both related. The stress and strain are two sides of the same coin. They are giving in the same direction. They are telling you the same. But actually, the strain actually signifies the change, the elongation, the actual elongation, or the change in the lung that happens here. Like here, if you have a transpulmonary pressure of 12, you would have reached around 70% of the total lung capacity, and you have a strain FRC tidal volume to FRC ratio of 1. Okay. If you increase the transpulmonary pressure to 24, logically, you can see here it intercepts the strain of around 1.7, and if you increase the transpulmonary pressure, as we have seen by the example of the patient who is taking a massive inspiratory effort, look what happens to your strain. We said if you have a pressure exceeding, the transpulmonary pressure exceeding 24, you will have a very, very bad outcome. You will have a strain of 1.6, 1.7, 1.8, and if you have a very high pulmonary pressure here, you will have a very high strain, nearly 2, which is exceeded the stress of rupture. So only when you start to have exceeding, you have a transpulmonary pressure of 12, I'll be very happy. For example, like pulmonary pressure inside the airway minus the pleural pressure is around 12. Okay, so I'm nearly in the normal range of the total lung of the FRC, and I'm nearly third of the total lung capacity. I'm not doing any barotrauma. But once you start to exceed this test-strain relationship, you exceed the strain of 1, what happens here? You increase the biotrauma. Biotrauma, as we said, the release of inflammation and the cytokines due to the small cracking and small stresses, and on the stress points of the alveoli and the interface and the shear stress that happens by the volume and pressure relationship, until you reach the stress of rupture, until you exceed the maximal elongation of the collagen and the proteoglycan, and you break down your skeleton of the lung, and you have the volutrauma and the barotrauma. So the stress-strain relationship is this is the relationship between the stress and the strain. The strain on the stress on the left hand side and the strain on the right hand side. The strain is the elongation ratio, tidal volume to the FRC. The stress is the tension or the baseline pressure. Here, if it's 12 and you have a strain of 1 here, this is very good, because actually you this is a specific elastance of the lung, which is nearly 1 times the FRC. But if you have 24, you are actually 2 times the FRC. Your tidal volume is 2 times the FRC, and if you are 36, your tidal volume is equivalent to giving 3 times your FRC, and you are approaching, you reach the vital capacity. As I've said from the beginning, know your boundaries, don't exceed your boundaries. If you exceeded this boundary, you are rupturing your alveolus, and you have exceeded this relationship, and you have injured your patient. So starting from a strain of 1, here you are having biotrauma, and when you reach this, all the time when you increase, you are having increased chance of having more volume and barotrauma and stress of rupture of this lung. Okay. So again, the stress is the transpulmonary pressure, the strain is the tidal volume of the FRC. The link between them is the specific elastance of the lung, which is 12, equivalent to the pulmonary pressure, the barotrauma, and the volutrauma. So what are the factors affecting the mechanical power? As we have said, all the factors that we have said, none of the energy components, it fully accounts for the ventilator-induced lung injury. It will be very unfair to say it's only the tidal volume, it's only the plateau pressure, it's only the baseline PEEP, it's only the driving pressure, it's only the flow rate. As you have seen from the equation and the calculation that we have done together, it is not just one factor, it's the multitude of factors. You have to personalize yourself to increase the tidal volume or not, to decrease the volume or not, to manipulate the transmural pressure by decreasing the pleural pressure or increasing it, alleviating the negative inspiratory efforts by the patient, paralyzing the patient, as you know. Because for the same, there's also pits and falls. You might have the same pressure and a different strain for that, as you've seen, because it's not just the pressure, it's the driving pressure included. And it's not just the volume, it's the percentage of this volume to the FRC, okay? So it's not only the volume, it's the percentage of the volume to the total lung capacity. And it's not just the pressure, the plateau or the driving or whatever, or the peak or the beep or whatever pressure. It is the relationship of the transmural pressure. So that's how it is so interrelated. So what happens if the transpulmonary pressure is too low? If you have a very low, if you decrease it, or you have you are crazy about it, decreasing too low, you will have insufficient ventilation, insufficient lung expansion. The CO2 will rise, the pH will decrease, atelectasis, hypoxia, and then you will have, from the hypoxia, you will have pulmonary hypertension, RV failure. On the contrary, if you have it too high, you will have matrix injury, as we said, you have overdistension, and the overdistension will increase the pulmonary vascular resistance, decrease the cardiac output, and we have right ventricular failure also, and pulmonary artery pressure increase. Okay, so you shouldn't have neither too low transpulmonary pressure or too high transpulmonary pressure. And as we said, it's not the maximal pressure or the driving pressure, but the repeated intolerable strain excursions that inflict the ventilator-induced lung injury. It has been shown here that when you have a strain of 2.5, whatever your if you have exceeded the PEEP pressure or the peaks and the plateaus, here is the lung volume, the percentage, the tidal volume is 25%, the 50%, 75%, and here is the PEEP is the maximum. It is the ratio of this volume to reaching the total lung capacity. You are still here, even if you put a very high PEEP and a slow and a very small tidal volume. Here an average PEEP with a bigger tidal volume. Here is a very big tidal volume with no PEEP, okay, at all. But actually you have a very high strain. At the end of the day, when you have a very high strain, this is what matters. This is what matters. is the strain and the excursions of this strain, the power, the strain per minute, the energy inflicted every minute, every breath, okay? The amount of this strain that happens per minute, which is the mechanical power that you have given this lung, is the what matters. Not only the pressure, not only the driving pressure, not the absolute volume, but the relative, the volume in relation. That's we have seen in the I remind you here. The strain relationship is not the tidal volume pressure relationship. It's the volume, the tidal volume to the total lung capacity and to the relation to the FRC, and the relationship of the pressure inside minus outside. So it's two relations related, not like before as we use the mere volume pressure curves. Okay, this is also one fact of life. So when you have here a tidal volume, average tidal volume, which is equivalent to FRC, you might have atelectotrauma. If you increase the PEEP level and you have the same tidal volume, but the volume in relation, look at this volume. All this is the volume change. The volume change is much more than the FRC. How many times? Maybe 2 times or 3 times. So you are reaching the TLC, the total lung capacity here. This is the level of TLC, maybe 3 times the FRC. So it's not just the volume, you're giving 6 mL per kilogram, but you are giving 6 mL per kilogram in relation to this. His FRC is very small now, right now. His FRC is baby lung. He has a baby lung. So you have this 500 mL is too big for this patient. Okay. This is an example. If you have a normal patient, you're giving him this is the normal tidal volume. Normal tidal volume 500. Okay. 500 over the FRC of 2,500, you have no strain. The tidal volume over the FRC is nothing. But if you have in ARDS, you're giving him 500 mLs, okay? His old FRC is not anymore. He doesn't have this big lung anymore. He has a baby lung now. So 500 over 500, you are actually having a strain of 1. But if this FRC decreased, for example, is 250 his FRC, and you're giving him the same 500, you will have a strain of 2. Got it? So increasing or having the same tidal volume, absolute numbers don't matter. I don't care about the tidal volume number. I don't care about the pressure number. I don't care about the tidal volume number. We care about how much strain it's giving, which is in relation to the baseline FRC or the actual FRC, and we care about the transmural pressure that is affecting it. And actually, the target delta pressure of 12 may be also not the one that's inflating. If you have 12, but you don't know, actually you don't know the baseline volume or the stress at PEEP is unknown, or otherwise the delta pressure is acceptable. So a delta pressure of or transpulmonary pressure of 12, you told me, doctor, 12 is very good, and it has a stress strain relationship of 1, and this is specific elastance. Yes, this is a healthy person. In each person, you must keep in mind the baseline delta stress here. You are not if you are this is the pulmonary pressure. This is the physiological FRC. If you have a normal situation, you know the FRC of this patient, okay. But what if you have a PEEP here of 15, and you are giving him, and you are the stress is what at this time? The delta stress is 10 centimeters water, okay. But actually you are approaching the total lung capacity on 10 when you're not reaching the 25. You told me when you reach it when you have 25. It all depends on the baseline lung physiology. The baseline lung physiology, baseline volume, baseline PEEP, and the baseline stress at them. That's where it comes personalized medicine. You will have to recognize each patient. This patient, how much auto PEEP does he have? How much PEEP, the baseline, does he have? How much estimated FRC is inside this lung? Okay? And so Energy needs to be normalized. How can you normalize the energy? You normalize the energy by 20 joules giving to a mouse is not the same joule 20 joules giving to an elephant, or not. 20 joules, if you give a hammer on the head of this mouse, he will die. But you give it on the head of this elephant, you're just scratching him. So you should normalize the pressures. Like what you normalize? You normalize like this lung. If you're giving it, for example, 20 joules for all, this number, 20 joules for a lung of 1 liter, or a lung with 750 milliliters, or a lung with 500, only 500 mLs. No, of course, when you shrink the lung, if the lung shrinks, the power is concentrated. It concentrates the lung. You cannot give the same power to the mouse like you give it to the elephant. Here, for example, you will have the shared stress. If many ropes here carry this 12 kilograms, is it like when you only have 3 ropes carrying the same? 4 kilos per rope. Here, if you have only 3 ropes, you have a 4 kilos per rope, where actually here it was shared by all the ropes. You have 2 kilos per rope. So you have the same power if you have the lung, which is decreasing in size, or else you will have a maximum energy expenditure or maximum lung injury. So you don't say, I'm just giving him 20 joules to which lung? If your lung has shrunken and become a baby, you have concentrated the power and you are giving her lung injury. I know I've taken a lot of time. I tried to summarize at the end here. The tidal volume and respiratory rate, we have, when you increase the tidal volume by 20%, mainly the respiratory rate increases mainly by the double. But we haven't seen the same increase in the respiratory rate. The flow, like the tidal volume, and the PEEP also was only increased by 5% when PEEP was increased by 20%. So with PEEP application, there is an increase in the end expiratory lung volume, and by that it modifies the lung surface area able to receive the stress. It means like PEEP was associated with less energy expenditure and less mechanical power, may depend on the recruitability of the lungs. Okay, so in conclusions, the degree of the lung damage in the ventilator-induced lung injury can be linked to the amount of energy transferred from the mechanical ventilator to the respiratory system within a given time frame within a minute, for example. There are several ways of calculating mechanical power, from simple formulas to high complex equations. Efforts focus on normalizing mechanical power to the lung surface area, normalize it to according to its size. PEEP has less weight in mechanical power calculations than the other kinetic components, than the tidal volume, than the respiratory rate, than the flow. So you can put PEEP as you have seen, but actually the PEEP also changes in the FRC, the functional residual capacity, that is estimated. So to keep that in mind when you put the tidal volume, it is in relation to the FRC. Calculating mechanical power is an important step towards better care of critically ill patients. Normalization, I said it, of mechanical power to the lung size. And thank you.
شكرا جزيلا دكتور ياسر. المحاضرة طبعا very sophisticated، وكان حاضر 100، بس طبعا لما طولت شوية انسحب مثلا ربعهم، لكن لحد من ثلث ساعة كان وصلنا 100. إنما هي محاضرة يعني عايزة واحد كاتب لك هو most important benefit for me changing my way of thinking when dealing with mechanical ventilation. يعني في ناس اللي هم قعدوا للآخر بيقرروا إن هم استفادوا من محاضرتك العظيمة دي، وإن شاء الله لما ننزلها على اليوتيوب بتبقى الناس تقدر تسمعها مرة واثنين وثلاثة عشان تستوعب كمية العلم اللي فيها، لأن أنت فعلا يعني مسحت الميكانيكال فنتيشن بالتفصيل الممل من جميع النواحي، واتكلمت عن الفسيولوجي بطريقة رائعة. فطبعا ممكن الناس ما تستوعبهاش مرة، محتاجة انها تسمع المحاضرة دي مرة واثنين. فدي فايدة ان احنا بس احنا بنتأخر شوية في تنزيل المحاضرات على اليوتيوب عشان يعني بتاخد وقت. اللي بيساعدنا فيها احمد طاهر ما بقاش فاضي، وربنا يسهل. هو الناس بتشكر اهو، ممكن تسمع وتقرا على الشات الناس اللي بتشكرك على المحاضرة الجميلة دي اللي هم صمدوا للآخر. Very interesting lecture. Give us great experience about targeted ventilation. دي بقى يعني شكر دكتور أحمد، شكرا شكرا. سيد كاشف. Thanks Professor Yasser. Good benefit new to me especially visual assessment. دكتور ياسر معانا وهتكون مشيت.
لا معاك يا بروف.
تقرا الناس بتشكر. أنا بحب أسمعك الدكتورة مي، شكرا جدا يا دكتور ياسر. دكتور عمر بيقول المكان اللي هننزل عليه. دكتور ماجد بيقول لك احنا قبل المحاضرة دي كنتش عارف. وواحدة بتقول لك انا يا ريتها انا سمعتها قبل كده وما شبعتش برضه، عايزة تسمعها تاني. دكتورة اسماء معجبة جدا بمحاضراتك.
هو بعد اذنك دكتور حسن، هو يعني المثال اللي حطه دكتور ياسر بتاع العيان اللي هو البلاتو بتاعه 21، لو حد مش شايف المحاضره هيبقى انا في السيف سايد والبلاتو 21 والبيك ادوب 30 ومش عارف له تايدال فوليوم، في حين ان هو العيان بيتضر اصلا عشان الميكانيكال اللي هو مش فاهم القصه. فده بيغير طريقه تفكير في الميكانيكال فنتيليشن للعيانين في اكيوت ريسبيرتوري فيلير. بصراحه محاضره لذيذه جدا وفيها معلومات زي ما حضرتك قلت يعني جامده. هي محتاجه الناس تقراها تسمعها كويس وبالراحه علشان تفهم كميه المعلومات الدسمه اللي فيها. ربنا يبارك فيك دكتور ياسر والف شكر. ربنا يخليك يا دكتور حسن.
تمام تمام. نشكر الدكتور ياسر. طبعا مش هيبقى في وقت المحاضرة التانية اللي كان المفروض هيقولها الدكتور شيرين فوزي. شيرين ده راجل ولا ست أنا مش عارف. دكتور شيرين ده من عندنا في القسم. كان هيقول محاضرة التروبونين في الأكيوت كوروناري سندروم في وجود كرونيك كيدني ديزيز.